Hello everyone, I welcome you once again to the course on Introduction to Medical Humanities. This is lecture 4 of week 1, and in this particular lecture we are going to discuss three major theorists who shaped the entire medical humanities discourse, so to say. They are considered to be the foundational theorists of this particular field of study. In the earlier lecture, we had discussed many keywords that are associated with medical humanities, and this particular unit introduces you to the broad theoretical aspect of medical humanities. Following which, of course, we will focus our entire shift to the Indian context. But for the time being, let me go ahead and introduce you to these three theorists. We begin with Susan Sontag and follow it up with Arthur Kleinman and Rita Sharon. Now, all these theorists, what they have done is they have reinterpreted the gaze of medicine. And why do I say that? Because they took many other considerations like social, like narrative competence, the kind of stigma that is associated with a particular disease, how does a person respond to a particular disease, all these aspects into the discourse of medical humanities. And therefore, their theories became central to how in medical humanities we started analyzing the texts that had actually depicted some of the diseases. We will begin then by Susan Sontag, Illness as Metaphor, Arthur Kleinman's The Illness Narrative, and Rita Sharon, Narrative Medicine, Honoring the Stories of Illness. In all these three texts, there is probably one thing which is important, that at all point of time, we have to remember that sickness is not just a medical story or a medical narrative. It is a human story. And therefore, it has to be seen in totality of the experience and not just the disease alone. These texts have Western origins, like I said earlier, but the implications are universal and thus relevant to Indian context as well. Let us begin with Susan Sontag, Illness as Metaphor, which was published in 1978. Now, for her, the journey was very personal. She herself went through a lot of effect of what you can call a medical condition, and therefore she used that opportunity, that experience, to discuss it in her book Illness as Metaphor. In fact, she suffered from breast cancer, and the moment we say cancer, it decodes different kind of meanings. When you ask a clinician or a surgeon or an oncologist, to be very precise, or an oncosurgeon, they will have different degrees of where they can demarcate a cancer. But in the narratives of Susan Sontag, she talks about how the fear of cancer, or the word in itself, is having a very fatal kind of repercussion. So, in this particular book, she tries to separate the metaphors of language used for illness. She says that societies impose punitive or sentimental fantasies upon certain diseases, transforming physiological conditions into moral allegories. Her opening phrase, "Illness is the night side of life, a more onerous citizenship," highlights humanity's dual existence in the realms of health and sickness. The metaphors used for the illness stigmatize the patient and put burden of illness purely on them. Susan also contends that extremes of romanticizing tuberculosis or demonizing cancer obscures the reality of the disease and demoralizes the patients with an interference with rational healthcare practices. To sum up Sontag's thought in her own words, illness is not a metaphor, and that the most truthful way of regarding illness and the healthiest way of being ill is one most purified of, most resistant to metaphoric thinking. What does this mean? That there are several kinds of realities of diseases, and metaphors just intensifies those repercussions. In fact, in literary texts too, Sontag observes that when dying came to be regarded in advanced industrial societies as shameful, unnatural event, so the disease which is widely considered a synonym for death has come to be seen as shameful, something to deny. This explains why, despite the advancement in medical treatments of cancer, the idea of cancer is often associated with death, arousing fear of the disease. Historically, tuberculosis exemplified romanticization during the 19th century. Authors used to get rid of the characters they no longer needed, like Little Eva in Uncle Tom's Cabin or Paul Dombey in Dombey and Sons. However, cancer does not get a poetic dissolution and gets painted as a shameful invasion of alien cells, escalating like a demonic pregnancy in the illness metaphors. Wilhelm Reich bioenergetic theories imply that the victim's repressed emotions cause this disease. And you will see that when we discuss stigma, shame and silence, you can categorize different kind of diseases within these categories. But there are so many diseases that are not so impactful in terms of just their medicinal value or clinical value, but there is so much of stigma and shame, and pretty much hush-hush kind of a situation. And therefore, Sontag made it a point to bring it to the forefront because she thought that it was an important discourse that was needed in terms of addressing. Then, when we move on to Arthur Kleinman, we find that his work, The Illness Narrative, published in 1988, is important because in this text, he distinguishes between illness and disease. A medical practitioner needs more than a diagnosis to understand illness. They need to listen to the patient's illness narratives. His journey began with a 7-year-old child who was being treated for severe burns and had to go through excruciating pain when burnt flesh was stripped off her body. He could not distract her from that pain until and unless he made it a point to discuss that pain in her own words. When she started describing her pain, it was then that he realized how relevant listening to patients' experience is in biomedicine. About that incident, he says, and I am quoting, "She taught me a grand lesson in patient care. That is possible to talk to patients, even those who are most distressed, about the actual experience of illness, and that witnessing and helping to order that experience can be of therapeutic value." And if at any point of time you have seen anesthesia being given, that is there where they begin. In fact, if you also have happened to go to a clinic for an injection, they will ask you simplest of questions. Where do you study? What is your favorite subject? Which is your favorite song? Or maybe to know more about you, but also to not just distract you from the pain is what I meant, but primarily to take into other aspects of your narrative into what you can call the illness narrative as well. So Kleinman talked about it in the first go in 1988, and before discussing the illness narrative, he distinguished between disease and illness, and he says, and I quote him, "Disease is what practitioners have been trained to see through the theoretical lens of their particular form of practice, whereas illness refers to how the sick person and members of the family or wider social network perceive, live with, and respond to symptoms and disability. From the point of view of a healthcare professional, a disease represents an abnormal bodily alteration which is manageable through diagnosis and intervention of medicine. However, illness constitutes the patient's deeply subjective and personal experience. It impacts an individual's personal, familial, and cultural experiences, and Klinman illustrates illness as culturally constructed and polysemic. He says that beliefs, values, and practices of a patient and their surroundings impact the healing and experiences of the disease. The distinction becomes more consequential in the realm of chronic illness, as acute diseases often lend themselves to cure, but chronic conditions occupy a different temporal space. In that sense, chronic illness is not an episode but a condition of living, and Klinman argues that nothing so concentrates human experience as serious illness. Further, Klinman also argued that the importance of medical history as told by patients is the way in which the doctor decodes or makes the diagnosis. Medical history as told by patients can be clumsy and poorly implemented, but even then it is a chance for clinician to understand or to make that particular diagnosis vis-a-vis that patient. Listening to the patients actually, or the narrative that the patients make, helps the doctor to understand what is the experience of the patient. Klinman says that one should be versed in deciphering the random stories and experiences shared by these patients. Someone who is listening to those narratives should be able to assign meanings to the components of the story and convert it into an evaluative narrative that helps in better understanding of the patient. He says, and I quote, "When the patient under examination disrobes to expose a body covered with ugly scars of eczema or with raw red flaking plaques of cirrhosis, the practitioner should recognize that shame, hurt, anger, despair, or other constellations of feeling probably present. Illness narratives are therefore not ornamental stories layered on top of biological facts, but they are mechanisms of survival and therefore become both socially patterned and biographically distinctive." He also introduced the explanatory model of illness, which initiates some crucial questions. The questions that you can see on your screen. What is the nature of the problem? Why has it affected me? What treatment do I desire? What do I most fear about this illness and its treatment? Now, these questions are extremely important when you think about illness, because when you ask the patient what caused them illness, what do they fear most, and how it has affected their life, it opens up the possibility of interaction of different kind. Klinman argues that asking what the patient believes caused them the illness is what they fear most. The goal is not to abandon biomedical knowledge, but to create a kind of a shared knowledge, a shared kind of understanding that is inclusive of both the practices, that respects both the perspectives. We now move on to Rita Sharon and her book, Narrative Medicine, Honoring the Stories of Illness, is extremely important when it comes to medical humanities, because she brought in the concept of narrative medicine, and according to her definition, it is defined as medicine practiced with the narrative competence to recognize, absorb, interpret, and be moved by the stories of illness. Now, narrative competence in that sense means an ability to listen deeply and understand illness, not just as human biology, but as human experience. Sharon argues that contemporary medicine lacks singularity, humility, accountability, and empathy, and therefore, by developing narrative competence, healthcare professionals can offer more individualized and ethically grounded care while fostering meaningful healing relationships. She further talks about what happens in the scope of narrative competence. If you see this particular quote, which broadly sums up why it is important for the clinicians to listen to the other domains of illness apart from just the illness that one is talking about. She says that listening that goes on in the clinical setting qualifies as a consequential reception of autobiography. So, which means that if a person is narrating the illness that the person is suffering from and discussing different other aspects of its symptoms and reflections, the listening is not just then clinical, but it helps in the diagnosis. She also says that many times you come across a situation in which the narrative of illness gets reflected in the form of bodily symptoms absent in the stories of the patient. When these two messages are in conflict, it becomes difficult for the clinicians to choose which one to focus on, and this is where the narrative competence comes in. In fact, in some of the lectures that I take up later on, where I discuss mental health, I will discuss this particular aspect of Rita Sharon in great detail, because I take up short stories or I take up cinematic narrative in which the patients are saying or expressing a physical symptom, but it has nothing to do with the physical condition. In fact, it has to do with mental condition, and that is what these short stories reflect, to go beyond what can be said as symptoms and look into what has shaped or what has gone into the making of that symptom, which may not be physical. So, we take up those narratives later on, but for the time being, it is important for you to understand that narrative competence is primarily about not just the narrative that is associated with the medical condition, but more than that. The story is also associated with this, and the clinician's ability to tap that narrative and negotiate with it. In fact, Sharon also came up with the idea of close reading. Literature students must have read about this term in a very different context, but in the context of medical humanities, it is similar but not same. What is it then? So, in terms of Sharon, she aims to equip medical students with skills to open up the stories to their patients, and that is why she says that close reading, which is careful and sustained reading, where the readers focus on the written text and other literary aspects attached to the text, such as form, structure, and syntax, become important. She talks about five-fold approach to close reading: frame, form, time, plot, desire, where frame is locating the space of the narrative, which means where it began. The form is about the genre, structure, narrator, metaphors, allusions, dictions, maybe other things like poetry form, literary form. The temporality is about comprehending plot or multiple storylines. The plot also is about what requires action while discussing narratives of illness. And finally, the close reading reveals the desire of the patient to the clinician, the unsaid wishes, goals, or motivations that impact them. The understanding of the desire of the patients help in gaining clarity of their issues and a better framework for their treatment. In fact, all of us, I'm sure with no exception, have gone to doctors at one point of time or other for something related to us or to our family members or to our friends, and we will realize that somebody who has just listened to us for a very brief period and not very carefully, we do not find that particular clinician emotionally very satisfying. Maybe clinically, yes, but we feel that, oh, I wish the person had given me a little more time. And somebody who listens to you carefully, you make a repeated visit again and again is what I can say. So close reading is something that she said, and she said that when you discuss the patient-doctor relationship and the narrative in between, close reading is a method we can follow. Then she talks about these three concepts within the scope of how clinical practitioners should kind of go ahead and the narrative that is woven there. The attention, representation, and affiliation. Now, these are important terms because in attention, Sharon suggests a way of becoming a better receptive vessel for the narrative by emptying the self and accepting the patient's perspective and instances. With narrative training, one can achieve this state of attention, letting us both hear and answer the summons. In narrative medicine, a clinician needs to represent what they have witnessed because writing what has been observed sharpens perception and helps in discovering thoughts and feelings regarding the case. Sharon highlights that when health professionals write, in whatever genre and diction they choose about clinical experiences, they, as a matter of course, discover aspects of experience that until the writing were not evident for them. The cycle of attention and representation creates a contact between the clinician and the patient, and between clinicians themselves, which leads to their affiliation. It creates a sense of empathy and connection between patient and doctor, increases understanding amongst clinicians, and builds a community of caregivers. To further explicate this idea of attention, representation, and affiliation, she developed something that she refers to as parallel charts. So, if you look at this particular parallel chart, she says that it came out as a teaching tool in 1993, but what does it do? It aims to recognize more fully what their patients endure and to examine explicitly their own journeys through medicine. So, what she's saying that in parallel charts, the non-technical language captures the personal and metaphysical dimensions of meaning for both the sick person and those caring for the sick person. So, when you want to understand the suffering of the patient empathetically, using the narratives of their illness, these parallel charts come handy. And that is why she developed this concept of parallel charts and she began using it as a teaching tool. Finally, all these three theorists shape what you can find in medical humanities as a foundational theoretical concept. When it comes to Susan Sontag, we come across how the language surrounding disease reminds us of the power of metaphors and therefore calls for clarity and dignity in care. When you come to Arthur Kleinman, the basic idea is the difference between disease and illness. It asks practitioners to listen deeply and recognize the suffering of the patient. And finally, when it comes to Rita Sharon, she talks about listening using the narrative competence. She gave us tools like close reading, parallel charts, the idea of attention, representation, and affiliation. in the way we reimagine medicine as a relational, interpretative, and moral practice of not just storytelling, but also way of knowing medicine. Here is where I will stop. In the next lecture, we will move our focus to Indian context and hopefully more familiar ground to tread on. Thank you so much.